We are now going to watch a 5-minute video that was created by the ICE Learning Center. I know you have used these videos before in previous courses. What is great about these videos is that they are of real treatment sessions, evaluations, assessments that took place in real skilled nursing facilities. These are not actors. So this is all very authentic. We're going to watch this 5-minute video of this woman named Joe, and we're going to apply different lessons to the case as we go through the rest of the lecture.
Good morning, Joe.
Well, good morning.
How are you today?
I'm doing fine.
Good. We're going to get started with some work at the sink. Have you washed your face and brushed your teeth this morning? Is that okay? Why not?
I didn't get around to it.
I know, so we're going to do it at the sink. Is that okay?
Yeah.
All right. All right, let's bring you over to the sink.
All right.
Can you turn on the hot water for me? And then it'll take a couple minutes for it to get warm, okay?
Well, we won't say a thing about it, will we?
No. Be our secret. Is it warm yet? Touch it and see if it's warm. Is that warm? No. How do you know which one is the hot water and which one is the cold?
Well, the one that has the cold, it has the red hat on.
The red hat is the cold one or the hot one? Which one is it?
That's the hot one.
What color is that?
Red.
Right. So the hot water is the what? It's red on top, right?
Right.
So what about the cold water? What color is that on top?
Well, that's not impressive.
No, not impressive. So do you know what temperature that water is?
That's supposed to be cold.
That's right. And how can you tell that?
Because it's blue.
That's right. Very good. Let's put it under the water so we can get it wet.
Okay, we can do that.
Okay. You need a little help?
I just might, you know that?
Okay. Here, you hold onto the washcloth. Let's put it under the hot water.
Okay.
Is that warm enough?
It's coming down the trail.
All right. Let's put it under the water. And I'm going to wring it out for you, okay?
Okay.
Yeah, it could have been. Now I'm going to give you this mirror so we can get a little closer. And then I'm going to have you wash your face and wipe around your mouth, okay? All right. Can you see it?
Ooh, trick or treat.
I think it's a treat.
Okay, you say so.
I'm going to have you wash your face, Joe. So use the washcloth. Let's wipe around your mouth.
Okay.
Can you see it in the mirror?
Mm-hmm.
Or is that mirror better? Would you like for me to help you?
Well, let's see which way it goes.
Okay. All right. So I'm going to set this mirror here, and we'll use this one.
Okay.
Okay? So let's put the washcloth in your hand, and we're just going to wipe around your mouth. Let's try a little more, okay? And if I can take your washcloth, I'm just going to wipe right here, okay?
Okay. So now we have met Joe. I want you to think about what setting Joe might be in. Now, this is still very early on in your learning about older adults. So I'll answer some of these questions, but I do want you to consider them as we go through. So, what setting is Joe in? It most likely looks like a skilled nursing facility that has a subacute rehab as a part of it. It could also possibly be an acute rehab if Joe had a recent fall or a recent health incident that caused her to need more intensive therapy in an acute rehab. But most likely, this looks like a skilled nursing facility. You see that Joe has most likely some form of dementia. I want you to think, does this mean that she has Alzheimer's? We'll have an entire lecture on Alzheimer's towards the end of this summer semester. But my response for you is no, it does not mean that she automatically has Alzheimer's. There are many different forms of dementia that you will learn about. Now, because she has dementia, does this mean that she shouldn't be getting therapy? And we'll learn about the public policies that have impacted Joe's ability to still receive therapy services, even if she's not making progress or significant progress. She may still need therapy to maintain or prevent further functional decline. And we'll talk about the act that put that in place. So, we're going to talk about public policy and healthcare now. This is a lot of the nit and gritty that you may have already heard about in some of your courses, but now again, we're applying it to older adults. So, policy reflects society's values and beliefs. In most developed countries, there is some form of universal health coverage. In the United States, there are three laws that are most salient to the health of older adults, which are Medicare, Medicaid, and the Older Americans Act. Medicare was enacted in 1965. It's paid in part by the worker and employer contributions and in part by insurance type premiums. Universal coverage for those who are over 65 and for individuals with disabilities. Part A covers hospitalizations, skilled nursing home care, home health care, and hospice. Part B covers physicians and other healthcare providers, and we'll go into more detail about that in a few slides. Part C covers Medicare Advantage plans, and Part D covers prescription medications. Medicare is designed to provide financial assistance for those who are at risk for requiring moderate to high levels of medical care. Medicare is multi-generational. Workers put money into the system through payroll deductions and self-employment tax contributions. Medicare is the largest single payer of healthcare services in the United States. Medicare influences provisions of other insurance plans because of its size and its scope. For eligibility of coverage, an individual must be at least 65, have been a U.S. citizen or permanent resident for at least 10 years, and have paid or a spouse who has paid Medicare taxes for at least 40 years, or they may be permanently disabled if they are not 65 years or older. Medicare is the primary source of payment for older adults. Items in Part A, B, and C are relevant to OT and PT and other therapy coverage. Medicare Part A. To be eligible for coverage, this is going to be repetitive, but a person must be at least 65 years or older, have been a U.S. citizen or permanent resident for at least 10 years, or have paid or a spouse who has paid Medicare taxes for at least 40 quarters. Individuals under 65 are eligible if they are permanently disabled, receive Social Security disability payments for at least the previous 2 years, receive Social Security disability benefits for ALS, or need continuous dialysis or a kidney transplant. Beneficiaries will have experienced an acute medical crisis requiring hospitalization, followed by a lesser level of inpatient care in skilled nursing facilities, or also called as a SNF. Hospital benefits cover acute illnesses, diseases, or surgical care, typically for just a few days. Hospital and SNF benefits include room and board and medically necessary professional services, such as therapy services, that must meet program requirements. When a beneficiary no longer needs the services provided in the hospital, maybe they've reached their goals to that specific care setting, or they've exhausted their benefits, additional therapy and services then can be provided within the home. Copays and other out-of-pocket expenses are part of the plan. Hospice care is covered completely, and we will talk about palliative care and hospice care in your older adults 2 course. SNFs are covered for up to 100 days of rehabilitation. So if you are working in a SNF or you're completing a field work in a SNF, you'll often hear them saying, oh, this Mr. or Mrs. So-and-so is approaching that 100-day mark. We need to either plan for discharge or come up with what the plan is after those 100 days. Therapy services are included and help determine the level of reimbursement. Medicare Part B covers diagnostic, therapeutic, and preventative medical services, health-related professional services, durable medical equipment, also known as DME, prosthetics, and orthotics. Beneficiaries pay roughly 25% of the costs. Medicare Part B covers the services by independent occupational therapists, physical therapists, and speech and language pathologists, as well as outpatient therapy services in hospitals, SNFs, rehabilitation agencies, doctors' offices, therapists' offices, comprehensive outpatient rehabilitation facilities, or within the home, with a home health agency or a therapist by a private practice. Jimmo versus Sibelius is the act that I was speaking earlier about in relation to Joe. This changed individuals' eligibility for Medicare services in 2013. Previously, progress and or improvement was required for skilled nursing home and home health care care. Findings in this action changed this so that functional maintenance and delayed decline as outcomes are covered. This is significant. The lawsuit filed by Glenda Jimmo and advocacy groups challenged the practice of when Medicare denies coverage based on a beneficiary's lack of improvement, even when skilled care was needed to maintain their condition or prevent further decline. The settlement required that CMS, which is the Centers for Medicare and Medicaid Services, needed to clarify that Medicare covers skilled nursing and therapy services for beneficiaries who need them to maintain their current condition or slow functional decline, regardless of their potential for improvement. To be considered skilled therapy, the services must be the level of complexity and sophistication that they require the skills of a qualified therapist and be reasonable and necessary for the treatment of the patient's condition. So, a question for all of you: what populations do you think would benefit from this big policy shift? The populations that come to mind are individuals with ALS, MS, Parkinson's, Alzheimer's or other dementias, diabetes, hypertension, arthritis, heart disease, and stroke. We're now going to speak about Medicaid. This was enacted in 1966. It's termed as coverage for the indigent individuals of any age. It also covers some long-term care for older adults. Medicaid is a combined federal and state insurance that addresses the healthcare needs of indigent individuals as per the Medicaid website. For chronic conditions that could lead to institutional residence, or also known as nursing homes, Medicaid can pay with options such as individuals, sorry, can pay with options such as self-pay or long-term care insurance. But for those who do not have any personal resources, Medicaid will step in. Like I said, Medicaid is a joint federal and state program. Since programs vary from state to state, criteria can be complicated. Individuals need to satisfy federal and state requirements regarding residency, immigration status, or U.S. citizenship. moving toward HMO type plans and away from fee for service. HMO plans are health maintenance organization plans, which this is the type of health insurance that typically offers lower premiums, but restricts coverage to a network of doctors and hospitals. And with Medicaid, there's the concern for the spouse of the individual remaining in a community because of the spend down provisions if all of their funds are tied together. Individuals need to satisfy federal and state requirements, like I said, that look at immigration status, documentation of US citizenship, and income. Long term care coverage is available only to those who have no financial resources. So, again, recipients with assets are required to spend them down to become eligible. And this is, again, something you may be hearing about if you're working in a skilled nursing facility and someone is switching to Medicaid payment for their insurance payment. You may hear about spending down and the concerns for their spouse and their family and the community. So let's go back to Joe. I want you to take time after this video and think about what possible insurance coverage does Joe have? There's not one right answer. And I want you to think about what your reasoning is.